Hey everyone, it's your Sedative Physio Akshay Kumar and I welcome you all to this new video, to this new lecture. In the previous lecture, we had started a series of the PT orthopedics, and in that first lecture, we had discussed generally about the general principles for the shoulder rehabilitation, right? Now moving further in the PT ortho, this is our second lecture, and here we are discussing about the shoulder injuries. Now we have a lot of conditions related to the shoulder. We have the rotator cuff injury, we have the adhesive capsulitis, we have the slap lesion, we have the shoulder instability. So we have different type of lesion, we have a lot of conditions related to the shoulder joint. We will have a look on all the conditions one by one. But here today we are going to start our first condition of the shoulder, that is the rotator cuff injury. But before starting this lecture, some points that I want to discuss with you all, that we are going to start our next batch of the anatomy. If you are willing to join, you can directly get in touch with us on the Instagram or on the WhatsApp, or you can comment down on this video below. All the details of the course of the batch are just mentioned in the comment box, sorry, in the description box, right? Apart from the anatomy, we are also running the PT Neuro course, the Biomechanics Masterclass, and very soon we are also coming up with the Physiology Masterclass. So if you are willing to join any of this, you can directly drop a message on our Instagram or on the WhatsApp, right? So let's start today's lecture, the rotator cuff injury. Now, if you had watched our previous some lectures related to the biomechanics, you must have known that what is the role of rotator cuff muscles in the shoulder joint, right? See, first of all, let's have some basic knowledge about the rotator cuff muscles. Rotator cuff muscles. There are total 4 fibers in the rotator cuff muscle, and this rotator cuff muscle are mainly responsible for the stability. They are mainly responsible for the stability during the ROM, stability during the range of motion. Like if you are doing any type of movement in the shoulder joint, for example, if you are doing the abduction type of movement, in the abduction at the glenohumeral joint, these rotator cuff muscles are responsible for this abduction movement, as well as these are very much responsible for the dynamic stabilization. Whenever you study about the shoulder stability, the glenohumeral stability, you will get to know that there are two types of stabilization in the glenohumeral articulation. First one is the static stabilization, and the second one is the dynamic stabilization. The static stabilization is just due to the muscle tension or the ligament tension that provides the stability whenever our joint is in resting state. But whenever we are moving the joint, whenever we are doing any type of movement, in that particular scenario, the rotator cuff muscles are very much responsible for the stability. The contraction of these muscles makes the joint stable during the whole range of motion. There are 4 fibers, there are 4 muscles in the rotator cuff group, and these 4 muscles are equally responsible for the stability. Not only these 4 muscles, apart from these 4 muscles, we have a deltoid. We have a deltoid that is also very much responsible for the stability of the glenohumeral articulation. Right, now the rotator cuff injury. This type of injury is common in both athletes as well as the normal people. So in this lecture today, we are first focusing on the rotator cuff injury from the normal people, from the normal population point of view. Then furthermore, after discussing these all stuffs, we will have a look, we will discuss about the injuries of the rotator cuff in the athletes. In the athletes, when there is overhead arm swing, overhead arm activity, there is more overhead arm activity. In that condition, there are more chances of the rotator cuff injuries, like the bowlers, like the javelin throw game. Okay, so all the games, all the athletics in which there is an overhead arm use, in that particular condition, rotator cuff injury can occur. So, okay, so this is prone in both in the athletes as well as in the normal individuals, right? So today we are discussing about the normal individuals point of view, and later on we will have a look from the athletics point of view, that what is the mechanism of the injury in the sports persons and in the athletes. Okay, so rotator cuff injury. Now, what are the 4 fibers? See, what are the 4 muscles that constitute the rotator cuff muscle? First is the supraspinatus, second is the infraspinatus, third one is the subscapularis, fourth one is the teres minor. Okay, now what is the muscle attachments of these all 4 muscles? See, supraspinatus we can just visualize from a diagram. For example, this is your scapula. For example, this is your scapula, and here we have the spinous process. For example, this is your spinous process, right? And we are visualizing the dorsal aspect of the scapula. Now the area above the spinous process, this area is called the supraspinous fossa, and this supraspinatus muscle is present here. Next, the area below this spinous process is called the infraspinatus fossa, infraspinous fossa, and this infraspinatus muscle is present here. Now teres minor muscle is also present at this location. Teres minor muscle is also present at this location, right? And the subscapularis muscle is present on the costal aspect, on the costal surface, or you can say that the anterior surface of the scapula, right? So we have these four muscles that are responsible for the stabilization as well as the movement. Okay, in all these four muscles, the supraspinatus has a great role in the abduction. We generally say that the deltoid is the prime mover for the abduction movement, but it is not true, because the deltoid, the arrangement of deltoid, the direction of force of the deltoid gives more translatory force, gives more superior translatory force. So if only deltoid will work, what will happen? It will just pull this arm superiorly, and it may damage the coracoacromial arch and the other stuff that is present at this joint, at this location here. Okay, so deltoid individually cannot go for the abduction movement. Deltoid individually cannot help in the abduction movement, right? So what happens here? The deltoid gives a translatory pull. At the same time, as we all know, in the abduction, like if you are doing the abduction, in the abduction we have both translation and the rotation. See, we have the translation as well as the rotation. Okay, so whenever we are doing the abduction type of movement, the deltoid is giving the superior pull. At the same time, from here we have the supraspinatus muscle, right? And from here, supraspinatus is pulling the deltoid, it is pulling the humeral head in this direction, towards the medial direction. That is giving a rotatory component, right? So deltoid is giving the translatory component, and the supraspinatus is giving the rotatory component. These two muscles are responsible for here the movement. At the same time, the infraspinatus, the subscapularis, and the teres minor are responsible for the stabilization during this movement. So that's why these all muscles are interrelated for their function and for the stability of the shoulder joint, right? Now, these muscles are very much responsible for the stability in the glenohumeral joint throughout the range of motion that I have discussed just now, that these muscles are very much responsible for the glenohumeral joint stability. Now, stability is due to the compressive force by these muscles on the head of humerus through the glenoid fossa. Now let's imagine this is your head of humerus. Okay, let's imagine this is your humeral head. Okay, and this is the glenoid fossa, and this is what? This is the glenoid fossa. So what happens basically here? This is the lateral angle. Okay, it is something like this. Now what happens here? Basically this is the lateral aspect, right? And here we have the medial aspect. What happens that the muscles present here, the rotator cuff muscles present here, this basically pulls this humeral head in the medial direction, something like this. And due to this pulling force, the humeral head gets attached, the humeral head gets here in the contact with the glenoid fossa, and it is making this joint stable. Okay, so how the stability is provided? So stability is due to the compressive type of force by the muscles on the humeral head towards the glenoid fossa. So the humeral head is pulling this, the muscles are pulling this humeral head towards the glenoid fossa and fix it to the glenoid fossa. If there is any type of paralysis in all these muscles, there may be in such conditions there are chances of the shoulder joint instability, like the subluxation or the dislocation. Right. Now, infraspinatus and the teres minor works as the external rotators. Infraspinatus, it means the muscle that is present at the lower segment just below the spinous process, and the teres minor. These two muscles are very much responsible for the external rotation, right? If you're doing the external rotation, so these two muscles are responsible. Now, for the subscapularis works as the internal rotators. Subscapularis is present where? On the subscapular fossa, or on the costal surface, or on the anterior surface of the scapula. So this muscle is responsible for the external, for the internal rotation. Like if you're doing the internal type of rotation, this muscle is responsible. Now, these muscles have a great role in the abduction movement of the shoulder. I just have explained you that how these muscles are responsible for the abduction movement. Okay, so these muscles have a great importance in the abduction or any elevated type of movement in the shoulder joint. These muscles originate from the scapula. As I have already told you that the supraspinatus is originating from the supraspinous fossa, Infraspinatus is originating from the infraspinous fossa. The teres minor is also originating near the infraspinous fossa, just nearby the medial border, right? And the subscapularis muscle is being originating from the subscapular fossa or the costal surface, right? And these all the muscles comes here to insert into the proximal humerus near the greater tuberosity. These all muscles are located here in the, near the greater tuberosity. Okay, the supraspinatus come in this way. It crosses the glenohumeral joint and just insert at the greater tuberosity. The infraspinatus same comes and it will cross the glenohumeral joint and it will insert into the proximal humerus. So these muscles originate from the scapula, crosses the glenohumeral joint and gets inserted into the proximal humerus, mostly in the humeral head, near the humeral head, near the greater tuberosity. Okay, so all these rotator cuff muscles are basically inserted into the proximal humerus. Now, frequency of the tears. Now, these all were the some basic points about the anatomy and the biomechanics of the rotator cuff muscles. Now, coming towards the injury, so the frequency of tears increases with age, and full thickness tears, it's not re, it's R. Full thickness tears are not common in patients younger than 40 years. Now, furthermore, in this lecture, we will discuss about the types of the rotator cuff injuries, and at that point, we will discuss that rotator cuff injuries can be classified on different basis, right? One of the basis is that what is the amount of tear, what is the level of tear. Okay, if it is partial tear or if it is complete tear of the rotator cuff muscles. Okay, so here in this sentence it is just gonna say that the complete tear, it means the complete rotator cuff tear, it is not common in younger patients, right? Complete rotator cuff tear, full thickness rotator cuff tear is generally seen in the older patients above 40 or above 50 years old because of the aging process. Okay, it's a normal aging process, but the partial tear, it is generally seen in the young individuals till the 40 years of age. Full thickness tear cannot be seen generally in the case of 40 years of age. And one more point, the frequency of tear will increase in the old age, right? The chance of tears increases in the elder patient, that I have just told you that in the elder patient, due to the aging process, the chance of tear increases, and in that condition the healing also delayed. The healing is also delayed because of the low immunity, low body metabolism, low body metabolism function. Okay, so the chance of tear increases in the elder patients, in the older patients, and in that patients the complication can also increase. Genetic influence can also be seen in the rotator cuff tears. According to different researches, according to many articles, we can say that the genetic influence are also seen, not very much, but a little bit of genetic influence can be seen in the rotator cuff tear. Okay, now we have different types of rotator cuff tear that I have just told you way back in the last slide. So rotator cuff tear classification is based on different points, is based on different factors basically. First factor is the based on timing. If there is the on the basis of the timing, it can be acute or the chronic rotator cuff tears. Chronic rotator cuff injury is very difficult to recover, but still we can recover it, but it is very painful. Now, based on the amount of tear, whether it is partial tear. Partial tear means that some fibers have been injured while the remaining fibers are still healthy, are still present. Okay, and the full thickness tear, this is more complicated as compared to the partial tear, because in the full thickness tear generally open surgery is preferred, right? So full thickness tear, it means that the whole fiber is completely damaged. But in the partial tear, we see that some fibers are damaged, some fibers are injured, while the remaining fibers are still healthy. Now, based on the mode it means what? That how the injury has occurred. Now, we have three modes. I have just written two modes. We have three modes. First one is the structural, or we can also say that degenerative. We can also say degenerative, like because of the overuse or because of any structural issue, around the shoulder joint, the rotator cuff tendons, the rotator cuff muscles are gonna injured. So these are the structural or the degenerative. This is generally seen in the old age patients, in the aged patients. While second is the traumatic. Traumatic, it means what? Due to any trauma, if there is an injury in the rotator cuff muscle, if there is a tear in the rotator cuff muscle, it is said to be traumatic. Now if we are dealing about the traumatic, then in the case of children, in the case of younger patients, traumatic type of tear is more common. Structural tear is generally not seen in the younger patients, because in the younger patients the tendons, the muscles are very healthy, while in the case of the older patients, we generally see the structural or the degenerative changes, while in the case of younger patients, traumatic tear is very common. Now the size of tear, like if there is a tear, there will be some size, and according to the size of the tear, the severity depends. So we can have 4 different classification of the size of tears. Starting from the smaller one is 0 to 1 centimeter square, it is the mildest form of tear. Medium, it is 1 to 3 centimeter square. Large, 3 to 5 centimeter square. And massive, if there is more than 5 centimeter square of tear in the rotator cuff, that is massive, and it is very much complicated to treat. Open surgeries are preferred, tendon transfers are preferred, and rehabilitation goes a way long, right? So we have these 4 classifications of the on the basis of the tears that define the severity of the tear. Now after that, clinical manifestations. Now if you are dealing with the clinical manifestations, there are some common clinical manifestations, but some special that is related to the rotator cuff tears are: first one is the traumatic tear is generally seen in the children. I just have told you that if there is traumatic type of tear, it will be in the children, or vice versa. We can say that if there is children, then in that condition we will see the traumatic type of tear. We can't see the structural or the degenerative tear in the children. A structural tear is seen in adults more than 40 years of age, right? Now there is one pre-assumption. The pre-assumption is what? If pain in, it is not in, it is if pain is present in adult above 60 years, it is presumed rotator cuff tear. Now it is very important point to discuss about. Whenever a patient, whenever an whenever an older patient comes to your clinic for the treatment of the shoulder pain. Okay, so in that condition, if the patient's age is above or near 60 years, it will be pre-assumed by you that there must be rotator cuff injuries until it is proved that there is some other condition with the MRIs or any other investigations. Okay, so it is presumed rotator cuff injury until proved any other condition, right? You will have to assume that the person may have the rotator cuff tear. Now night pain is one of the major feature of the rotator cuff. Night pain is very serious. Even the patient can't sleep without because of the pain. If the patient is sleeping and he turns on the affected side, then he will just awake, right? So the pain remains too severe to prevent the sleep of the person. It will awake the patient if the patient rolls on the affected shoulder that I just told you. Now the patient gets relief by placing the affected arm overhead with the hand placed behind the head, something like this. Overhead with the hand placed behind the head, something like this. In this position the patient will feel relief. This is called the Saha position, right? This position is called the Saha position. Now there is a problem with this position. If the patient is in this position, then the patient will not able to keep his arm back to normal easily. Okay, there will be very pain if the patient is gonna come back to its normal position from the overhead arm position. Okay, so this is the issue with this position. Now the pain is less with arm used below the chest. If I will use the arm below the chest level, there will be no pain, but the pain will increase whenever I will try to go beyond 90 degrees of the range of motion. In that condition, the pain will increase more, right? Now the lowering arm from the overhead is very difficult. That's what I have just told you, that if the patient is in this position and he wants to get back to the normal, in this condition from the overhead arm position, if I am gonna take the arm back to the normal position, this will be very difficult for the conditions for the patients of the rotator cuff tear. Now crepitation sound may be present, but only in the chronic full thickness tear, right? So you can during the assessment you can just keep in mind these points, like if there is any crepitations, there must be the chronic condition or there are chances of the full thickness tear, right? Now the pain doesn't radiate distal to elbow. This is very important point. The pain will be present in this location, but after the elbow, okay, after the elbow the pain will not present. It will just present in this proximal segment near the shoulder joint or the upper arm, right? Now the pattern of tear, whenever the rotator cuff tear occurs, there are different patterns through which the tear will occur. First is the crescent shaped, or it is called the moon shaped, basically moon shaped. See, this is what, this is IS, it means the infraspinatus, this is the subscapularis. Okay, no, this is the supraspinatus, and here we have the spinous process. So what is happening here? This is the tear. Now see, this tear, this is like the moon, right? This is like a moon. Okay, so this is the tear, this is the crescent shape, this is the mildest form of tear, this is the mildest pattern of the tear. This is very easy to repair because of the see here, the tendons, not tendons, the edges of the tear are very closer. That's why it is very easy to just repair this surgically. Okay, now this is very easy to repair. Substantial amount of medial retraction is seen. The retraction after the tear is very low. See, this is the retraction. This is very low retraction. We will compare it with some another types too. So, okay. That's why since there is very less medial retraction here, so it is easily mobilized with less tension during the treatment. Okay. Now moon shaped tear pattern, I just have told you. In this condition, the recovery is good. If we can recover the patient, we can get the patient back to the normal work very soon after the rehabilitation. So this is the crescent shape. Next one is called the U-shaped. This is the U-shaped. Now see, this is just the more elongation, more elongated version of the crescent shaped. Crescent shaped was something here, it was something like this, and in the U-shaped, this is retracted more towards the medial aspect. This is the medial, this is the lateral. Okay, so in the U-shaped, it is called the extensor of the crescent shaped tear that have retracted further. In the crescent shaped, the tear was, the edges was here, but when it will get more retracted in the medial aspect, it will just become a U-shaped tear, and hence it is called a U-shaped. Here large margin convergence is used to repair this. Okay, now see what does it mean. For the repair of this tear, for the surgical repair of this tear, what will the surgeon have to do? The surgeon have to pull this margin, okay, pull this all margin, and the surgeon will have to stitch it here so that the repair can occur. And in this condition, see, this is retracted very much, very far away from the point of attachment. That's why in this condition, large margin convergence is used to repair this. And in this condition, muscle tension plays gives some complications, right? Now, after U-shaped, third one is the L-shaped or the reverse L-shaped. Here, what happens? The tendon tear from the tuberosity is not for, it's from. Tendon tear from the tuberosity. Additional longitudinal split posteriorly or anteriorly. Now see what happens here. See, this is the L-shaped tear, right? See, this is the L-shaped tear. This is what we say L-shaped tear. It will shape like L. Here also, here again, the surgical management is needed. Through the surgery, we will manage it, and then after the surgery, post-operative rehabilitation will start by us. Right? Next one is the type of repair. We have generally three types of repair. This is surgical. We will repair the rotator cuff injury surgically. So we have three types of repair of the surgical, of the rotator cuff injury. First is the open repair. Open repair, it means what? We will make a large incision at this point, and after making a large incision, we will just repair this. Okay, this is very much useful whenever there is the detachment of the deltoid muscle, right? See, in the open type of in the open type of repair, in the open surgery, active motion is not allowed till 8 to 12 weeks. We are not gonna discuss about the surgical process here because we as a physio don't need about to know much about the surgical process. We have to know about the rehabilitation protocol. So if there is open repair, if there is open surgery, in that condition, post-operative, we will not allow the active motion till 8 to 12 weeks, mind it, okay? Now, acute genital strengthening isn't allowed till 12 weeks. Just keep this data in the mind, right? That in the open type of repair, active motion will not be allowed till 8 to 12 weeks. The acute genital strengthening will not be allowed till the 12 weeks. Okay. Now, in this condition, the patient isn't able to comfortably elevate above the shoulder level up to 6 months, right? Up to 6 months after the surgery, the patient feels uncomfortability whenever the patient is gonna go for any movement above the shoulder level, right? The patient will feel uncomfortable. This is the open type of repair. Second is the mini open. Mini open is just like the open type of repair, but here is the very less incision. About 3 cm of the incision is done here for the management, for the repair of the rotator cuff injury. Okay, it will allow mild and early deltoid muscle contraction. In the open type of injury, in the open type of repair, the deltoid contraction is prohibited for up to 6 months, not 6 months, up to 12 to 15 weeks. But in the case of mini open type of repair, early deltoid contraction can be initiated by us during the rehabilitation. Okay, it doesn't create surgical morbidity, and in the case of open repair, it creates surgical morbidity. Rehab is progressed faster because the incision is very low, the wound healing is faster, the wound healing remains faster, and hence in that condition rehabilitation, we can start the rehabilitation earlier and it will progress more faster. Incidence of shoulder stiffness is seen. There is only one challenge with the mini open type of repair, that in 11 to 20% of the patients post-operatively shoulder stiffness is seen. This is the only drawback. With the mini open type of repair. Third is the arthroscopic, that is very much trendy nowadays. Arthroscopic repair is very much on trend nowadays. There is slow rate of rehab progression. That's the issue with it, that the rehab progression is very slow. But one good point with the arthroscopic is that here the deltoid attachment is completely preserved. Second point, there is no stiffness seen, as we have seen that in the mini open 11 to 20% of the patients feel the shoulder stiffness post-operatively. But in the case of arthroscopic surgery, arthroscopic repair, there is no history, there is no incidence of shoulder stiffness here, right? And there is a preservation of deltoid attachment. And one more point, that there is very less pain post-operatively. Okay, so these are the three methods of the repair, but among these three methods, arthroscopic repair is very trendy nowadays. Most of the surgeons prefer arthroscopic type of repair. But if there is a deltoid detachment, in that condition we have only the open repair type of option. So it will always depend on the type of patient and on the severity of the case, right? Okay. So this was some basic points about the rotator cuff injuries. Now in the next lecture we will have a look on the examination for the rotator cuff injury and the management and the PT management. Then we will move on towards the rotator cuff injuries for the athletics, for the sports person, right? So if there is any doubt in this whole lecture, please let me know in the comment section. And most of you had asked me to make the lectures in English language, so here it is. I have made the lecture in English language. I will try to make the lectures in both the languages alternatively, in the English as well as in the Hindi language. And if you are willing to join our batches, if you are willing to join our masterclass, you can just simply drop a message on our Instagram or on our WhatsApp. The number of our WhatsApp number is just mentioned in the description box below, or you can also join our WhatsApp. So I will see you guys in the next lecture. Till then, be happy and keep learning.